YouTube channel, AF Medico, and on this YouTube channel I will put this lecture, and here is the lecture from the Neurotology Congress that Dušan also held a few months ago. And here are some lectures about facial nerve reconstruction, mastodectomy, and a number of lectures. And I am adding these lectures to this site. So you can go to this AF Medico YouTube channel and find it there. Now, this also is my website. It's undergoing a revision right now, so if you don't find it exactly, it will be again. But this is andrewfishmanmd.com, and there's a lot of resources specifically on skull-base surgery, neurotology, especially in this area here, specific clinical interests. So if you go through here, anything that has blue also has some films and additional information. And I'm going to start with just a small video on superior canal dehiscence syndrome. Because superior canal dehiscence syndrome is something that is very effectively treated by surgery. The candidacy, I think you discussed at length already, or will discuss, Dušan, yes? Yes, tomorrow. But how to fix it is, you can look at this video, and I'll show it now. It's on my website. It's actually very easy. Some patients require a middle fossa craniotomy, but some patients can have it done through the mastoid. And this is a minimally invasive mastoid. So this is a left ear, and I'm doing a mastoidectomy, and I'm keeping the bone dust, and I'm keeping the cortical surface of the mastoid to resurface the floor of the middle fossa. Because the patients with superior semicircular canal dehiscence also have defects in the tegmen, or the floor of the middle fossa. It's very common. It's kind of a developmental anomaly. So you will find not just the dehiscent canal, but you'll also find many holes in the floor that need to be resurfaced. And in this particular patient, especially if the dehiscence is more on the lateral or posterior aspect, you can easily see it by elevating the dura and putting in a little endoscope. So I put an endoscope here, and we can see here the fistula. See, so here is the fistula right here. And this is the dura, and I'm going in through the mastoid, and I use an angled endoscope, and I'm going to plug and resurface this so that it's actually a fairly large fistula. And I will use a combination of bone dust and this bone plate. And this is a pretty safe procedure because it's done without a craniotomy. In many patients, we can accomplish this. So I'm putting first some bone pate to fill it. You know, you can just use bone wax, and sometimes we just put wax, bone wax, surgical wax. But there's a little more of an inflammatory reaction to bone wax, so it's a good idea to start with some of the patient's own natural bone or the patient's own fascia, and then compress it in. You know, initially we just try to resurface them to try to keep the lumen open, but most of those patients required a revision. So now we just gently compress it. And then here I've shaped the bone that I took off of the mastoid cortex, and I have a little plate. I made a little notch in it so I can move it, and I'll just slide this up over to resurface the floor of the middle cranial fossa so that the patient doesn't develop an encephalocele. Okay? And this type of patient can be done even as an ambulatory operation and go home same day. The chances of hearing loss are still, we have to tell them honestly, is about 1%. It's not high, but it can happen. But 99%, they won't have any hearing loss. And what they will have, which is interesting, is they will have a new kind of vertigo. They will have a vertigo from the loss of the function of that single anterior canal. But that compensates after vestibular therapy. But immediately after surgery, they lose the audiological symptoms, the sort of double sound or the hearing their own voice or the noise-induced vertigo. They lose that right away. So the most beneficial symptom for superior canal dehiscence is the audiological symptoms. Those go away quickly. The vestibular symptoms go away, but with time. It's a very effective operation. And the presenting complaints can be quite varied in the hearing loss. I've seen patients with almost a pure high-frequency sensorineural hearing loss that also recovers. So yes, we understand this idea of the cochlear conductive, and I think tomorrow you will discuss this, but the hearing results on the preoperative testing are not always consistent. So I'm concerned less about that than I am about the VEMP. The VEMP is really the most important test that shows that there's the dehiscence, and the radiology. Okay, so now, how many of you were at my lecture in acoustic neuroma in the Neurotology Congress? No one. Okay, so maybe, but not everyone.
4 or 5 of them.
Okay, good. So and then there was also a surgical vertigo lecture at that Congress. Okay, so, and I also have something on facial nerve surgery. So I think I will touch a little.
Minority of people.
Yeah, good. So I don't want to repeat, because also they also are on the website. So if you get the complete. So let's move around a little bit, and let's start with surgical treatment of vertigo. I think this is a very good topic to begin with. Now, the surgical treatment of vertigo, let's see, hold on, let's see. Okay, I'm going to show some case examples. So this patient is a young adult, underwent right-sided endolymphatic sac decompression with a shunt 4 years earlier, and still reports dizziness that occurred daily and vary in length from 45 minutes to a few days. So it's long enough to be consistent with a Meniere's disease, and it was already operated, but still has the symptoms. Okay, has otalgia, has oral fullness. Now, this is the hearing loss. So we have a flat sensorineural hearing loss, but still have a 72% speech understanding. You know, this kind of patient is sort of on the border between someone that we would like to do a hearing preservation procedure or a hearing ablation procedure, like a labyrinthectomy or gentamicin or nerve section. Now, what are our options? Well, if we give this patient gentamicin with a significant sensorineural hearing loss and a 72% speech understanding, there is about a 40% chance that they're going to lose some high-frequency sensorineural hearing. And this won't be usable hearing. Right now, with a hearing aid, it's acceptably usable hearing, and it fluctuates still. So I wouldn't use gentamicin in this patient. There is the possibility of doing a nerve section, but through either retrosigmoid or the middle fossa, which is done to preserve the hearing. But this is an intracranial operation. It's a fairly significant operation, higher risk operation. And the patient's already had an endolymphatic sac shunt that supposedly didn't work. So the first thing we're going to do, and this is, I see a lot of this. Also, look, see, so we're going to do a rotational chair. We have right-sided 14% weakness, some mild asymmetry, but not bad on rotational chair. There's a little bit of reduced gain. And we're going to get a revision CT scan, a repeat CT scan. And this is the first thing I do in anybody who's had a shunt done before, because you can see here is where the endolymphatic sac should be. It should be just below the posterior canal and going all the way down to the bottom. And what do we see here? We see bone. So what did this patient have? This patient essentially had a mastodectomy. They didn't have a shunt. And this is very common, because to properly do a shunt, maybe here there's a little bit of bone missing. But this was not properly done procedure. And my The general reported outcomes, I'll show you my own, but the general reported outcomes with a endolymphatic sac decompression and a shunt is about 2/3 have either complete or less reduction of vertigo, and about 1/3 have persistent symptoms. So we tell patients that they have a 2 out of 3 chance that they will have improvement with a shunt. Okay? And I'll show you how this is done. Now, this is a revision shunt, but we can treat it as if it's the first time ever, just a little less work on the bone. Of course, these patients already had steroids. You know, we start steroids as the first-line treatment because there's very little risk in intratympanic steroids. But after a number of years of failed steroids and failed procedure, then it's very reasonable to try to do a shunt if you want to preserve the residual hearing. So here, this is a right side, so this is the sigmoid sinus, and this is the facial nerve right here, and this is the posterior semicircular canal. And you can see that all this bone is still present. So to properly do a shunt and sac decompression, you must remove all the bone off of the posterior fossa dura. And for someone like myself who is doing a lot of neurosurgery through the temporal bone, this is a fairly simple procedure. But if the surgeon is not so familiar with doing intracranial work in this area, they're going to be very afraid about getting a CSF leak. So that explains why you see inadequately performed shunts. Well, the truth is, if you get a CSF leak, it's not so difficult to deal with. You can just fill the area with some Surgicel or some materials and some taco seal, there's different materials, and stop it very easily. So, but the most important thing is that everything is very widely opened up. So I'm going all the way down, here's the facial nerve, I'm going under the facial nerve, and I'm going to the jugular foramen, and all of this blue that you see is the posterior fossa dura. It looks very blue, and this is scar tissue from the previous surgery, but there's still bone in this area. The endolymphatic sac is, here's the posterior canal, the endolymphatic sac is tucked under the posterior canal and covering the lower half. So one has to get very close to the balance canal. It's not adequate to leave this bone, so one has to go with a smaller and smaller diamond burrs and get underneath the posterior canal. If one accidentally exposes the posterior canal, you can plug the posterior canal, just like a superior canal, and they may have some vertigo from this, but it won't cause hearing loss. And many of these patients already have some hypofunction. This one didn't have much hypofunction, but that is also recoverable. So see, you have to take all of the bone off. Now, we don't really know why this operation works. I mean, it's not clear. Some people only do the decompression and get comparable results without putting the shunt. But I put the shunt, I just open up the sac. This very dense white structure is the endolymphatic sac, and it's, when you get it nicely exposed, you see there's like a center to it, and you can open it up and there's a pocket inside. And I put the shunt made of silicone, and there is some suspicion that perhaps there is some kind of an immunological response to the silicone. I mean, we know that silicone has some wound healing properties. You know, silicone is used for reducing scar formation in plastic surgery. So maybe there's some kind of immune regulation going on by opening this up. We do believe that the endolymphatic sac has some immunological property, and maybe some of Meniere's disease is based on an immune response. So again, it's not clear, but we know that historically, in large series, 2 of 3 patients respond. And this is a relatively low-risk operation. So why not try it? And often, this may be the first-line therapy for patients who have very good hearing and who are relatively early in their process of Meniere's disease, because you don't sacrifice the hearing and you don't sacrifice the vestibular function. Steroids are the same, but at some point steroids have a limited effect. So this would be the second intervention in an early Meniere's disease patient that's non-destructive. Okay? I also am putting intratympanic steroids at the same time. Why not? You know, we're there, so why not do the same? So let me go to the next. Let's see here. Good. So in 2014 to 2022 period, so that's about, what, 8 years, I think, if I'm doing my math correct? Or what? I just looked at the number that I did in Northwestern University before leaving in 2022 and coming to Belgrade. And I had 33 patients who underwent endolymphatic shunt with an endolymphatic sac decompression with the silastic shunt, and one also intratympanic steroid. Plus, they all did. They all had plus intratympanic steroid. And the results that I had from my patients, and it was basically based on a questionnaire, and I just broke it down a little more clearly, but not so much different than the original types of data. If there was clearly no benefit at all, it was none. If there was questionable, we really weren't sure. So we can group those together as not having a reasonable response. You see another 3% where we weren't really sure, maybe a little bit, but there was clear benefit in 3 of 4 patients. Why 3 of 4 patients rather than 2 of 3? Well, maybe because I'm doing the shunt, a lot of revision, and I know that it's being done completely as wide as possible. So there could be some benefit to the largeness of the exposure, but this is consistent with historical data. Here is another patient. So let's look at this patient. You see, not so different audiogram pattern, but worse word recognition score. Now, this 48% in this right ear is in a category, and this was a more consistent low functioning ear. And look at the testing, very poor performance in the right ear in caloric testing. So, and this is also a patient that had a very long-standing Meniere's disease. So this patient had more than 10 years of symptoms. The other one was 4 years, right? So if you get a patient that's had 10 years or more of symptoms, bad hearing, non-serviceable, and very bad symptoms, this is a very good patient for either gentamicin. You can try to overdose them on gentamicin, meaning that you don't carefully administer the gentamicin. You give them the highest dose and you do it 3 times in a week's or 2 weeks' time. You just try to completely kill the ear with gentamicin. This patient already had gentamicin. That's why they don't have much of residual function. So this is actually post-gentamicin and failed gentamicin. There is another thing about gentamicin versus a nerve section. Gentamicin is still an incomplete, as we can say, so it's a partial labyrinthectomy, chemical labyrinthectomy, and it also takes longer to have its effect. Now, if you have a patient that's been suffering from severe Meniere's, had multiple procedures, has been troubled with this for 10 years, the one thing that's going to get rid of their symptoms with the highest probability and the fastest is going to be a nerve section. Okay? Because the nerve section, you're going to take that function of that labyrinth from whatever residual percent to a true 0%. You're going to completely disconnect it, and it's going to happen abruptly. So from that moment, they're going to begin the process of compensation from the contralateral side right away at a set 0 point. When you use gentamicin, which is a slower and partial, that residual effect and that slower delay has some impact on the length of time it takes to recover. So the gentamicin will take, of course, it doesn't involve surgery, but it takes longer for the patient to get better. So there is a very good argument to use a nerve section instead of gentamicin for this reason. And the patient that's perfect for this is someone like this, who's been through a lot and has been suffering from this for many, many years, and they just want it to be finished. And this is the best way to do it, the closest thing to a complete 100% guarantee. So I'll show you. Now there's something else I want to point out. And I'll show you the results also. Patients with Meniere's disease, if you cut their cochlear nerve in addition to the vestibular nerve, I'm going to say all because I had 100% but you know, nothing is ever 100%, probably, let's just say. But all of my patients who I did this all reported improvement of the tinnitus. Now, tinnitus is a very difficult problem to fix, but Meniere's disease tinnitus is probably different than most other forms of sensory neural hearing loss-induced tinnitus. Meniere's disease tinnitus is, at least in part, from the ear itself. So disconnecting the cochlear nerve from the ear has an effect. While patients with tinnitus for all other general reasons, it's thought of, and we think it's mostly from the brain itself. So this part won't go away, but the part that's from the ear does have a good chance of getting better. So this type of procedure, I would say about 10 years ago was the best option for someone in this situation. Today there's a better option. I also did in this patient a BAHA, or bone-anchored hearing aid. But today, and I have a few patients that I did this to, it's actually a very good solution instead of this to do a labyrinthectomy only and put a cochlear implant. Okay, so patients that have Meniere's disease will benefit from the cochlear implant. It will be the only way to give them back their hearing, and it also helps with the tinnitus because stimulating the cochlear nerve with electrical stimulation also reduces the tinnitus. So today, unilateral severe deafness, long-standing Meniere's disease, probably the best choice is labyrinthectomy and cochlear implant. Okay? But this is expensive. Cochlear implant costs. So in some countries, in some places, we cannot do this. And it's unilateral deafness, and not all health systems cover unilateral deafness. Okay? In the United States, they did only about the last 2, 3, 4 years before I left. It was something relatively new for the United States to cover unilateral deafness to any extent. So here, I'm going to show you, this is a translabyrinthine going through the labyrinth, so it doesn't involve a craniotomy. It's all done through the temporal bone. This patient, you see, this patient already had an endolymphatic sac shunt. So now this is the right side, and I'm just opening up the mastoid very widely. It looks very similar to the previous operation. And in earlier phases, many of these patients will have had a shunt, and also helps speed up this operation because a lot of the anatomy has already been exposed. But I have to open, this is the sigmoid sinus, and I have to reduce it down out of the way to get to the balance canals, which are here. This is the back of the canal wall, the external auditory canal, the sigmoid sinus. This is the adytus with the incus, and this is the lateral semicircular canal and the posterior semicircular canal. And here I'm identifying the facial nerve going down to the mastoid tip. So I'm also now preparing the bed for the BAHA. So we put an osseointegrated bone implant in, get that all done, and then I'll do this as a single stage because it's an entirely sterile operation. So there's no risk to putting in a foreign implant. Because I'm opening up into the CSF space and we're going to section the cochlear nerve, I can plug the eustachian tube off because we're not going to be using the natural hearing anymore. So I'm opening up to plug the eustachian tube so we don't get CSF otorrhea. Cutting the tensor tympani tendon so I can put muscle in there. And now I'm going to do a labyrinthectomy. So it begins with a labyrinthectomy. And then I know the question that I'm often asked is, well, why do you need to cut the vestibular nerves if a labyrinthectomy should, in principle, reduce the function of the vestibular system. Isn't a labyrinthectomy alone enough? Well, the answer is maybe in many cases, but not always. And I'll explain that after I show this film. So here, the lateral canal, the posterior canal. And now I'm going to turn, and I'm going to complete this. Let me move it along a little bit so that we don't use up a lot of time. Here. So here's the labyrinthectomy is done. And now I'm going to open up the back of the vestibule right here. And this is the facial nerve. The vestibule has been completely opened. And here is the superior vestibular nerve. It goes to the lateral and the superior semicircular canals. And this is the superior vestibular nerve. And then going down inferiorly here is the inferior vestibular nerve, because that goes to the saccule and the posterior semicircular canal. Okay? And they're right next to each other. This is the very distal end. And that little dot you see here, that's the singular nerve. You're going to see it under here when I take the drill away. See, there it is. That little dot right there is the singular nerve. It's a separate channel coming off of the inferior vestibular nerve, right there, that little circle. So they're very close to one another, and I just have to open this lateral end of the internal auditory canal and gently section these nerves. So here they are. Here's the singular nerve, and now we'll open it up and get a little more exposure because I have to reach anteriorly to get the cochlear nerve as well. So let's move a little forward here. So we have the facial nerve, the superior vestibular, inferior, and singular nerve, and okay, there. And the cochlear nerve is underneath the inferior vestibular nerve in gray, okay? So I have to open it up and avoid the facial nerve and find that with the electrical stimulator, and then here's the inferior vestibular nerve has been cut, and that's the superior vestibular nerve now. And I'm using the facial nerve probe here to stimulate the facial nerve. It's right there. And I'm verifying that this is not the facial nerve. I just disconnect it. This is very similar to removing an acoustic neuroma. Just cut it, and then I'll go for the cochlear nerve. And there can be blood vessels in here, so one has to be very careful. This structure right here is called the horizontal crest in the end of the internal auditory canal, and the vertical crest is up here, in between the facial nerve and the superior vestibular nerve. So this is the lower half of the internal auditory canal is separated from the upper half by this structure, and here is the cochlear nerve. It's actually fairly broad, and you see this little artery that runs right along the cochlear nerve. That's the labyrinthine artery, and if that has a little embolism, that causes total deafness. And when we remove acoustic neuromas trying to preserve this nerve, we also have to preserve that labyrinthine artery. It's tiny. And the cochlear nerve is quite large, actually, and it looks much wider than the vestibular nerves do, and it's quite thick. And I need a little more room to cut this cochlear nerve than I would have otherwise. Here's the facial nerve. And that's that. So I plug it up with some fat and then put this Baha on, and that's it. This is called a Baha Attract. It uses a magnet. They don't make it anymore. There's other devices now, but that's that. So this is a very effective operation. If you want to tell someone, I can practically guarantee you that you're going to be cured. So auditory implants and Meniere's. So I had one patient with an endolymphatic sac and single-sided deafness that I put a cochlear implant. Another patient with a labyrinthectomy and single-sided deafness. So we did one with a sac and an implant, a labyrinthectomy and an implant, and then two patients I planned. These were patients with bilateral Meniere's disease, and this one also had a very bad cholesteatoma that had a subtotal petrosectomy, and then developed Meniere's disease about 5 years later in the same year, we put temporary electrodes. So it's also possible to put in a temporary electrode in plans for future cochlear implantation. The reason you have to do this is once you do anything else to the inner ear, they will fibrose the inner ear and you won't be able to put an electrode. So some procedures require you put a temporary electrode. Now, let's just go now to the overall series. So, vestibular nerve section alone, in one patient, the sac failed and underwent a labyrinthectomy 7 months later. But I offered the labyrinthectomy as the first line of therapy and the patient didn't want it. So it's okay. You know, they can try a sac, but usually this patient is going to be very similar to patients that fall into this category. A patient who has had more than 10 years or 10 years of vertigo symptoms and Meniere's, very little is going to help them except ablative therapy. There's something about this 10, 11-year mark that you will see that patients will have, for the couple of years, they'll go up and down with their symptoms, and they may even regress and be very quiet for a while, but then around 10, 11 years comes, and they start to get very bad symptoms. And patients, you see that, right, Dušan? They come at around 10 years. And if they're having drop attacks, also, those patients usually don't get better unless there's an ablative therapy. Okay? So long-standing Meniere's with a resurgence need ablative therapy. Whether it's gentamicin or whether it's a surgical section, they need it. You know, you're sort of wasting time with other things. So vestibular nerve section and cochlear nerve section, there's 11. All patients were indicated due to disabling or a major concern for tinnitus. All of them with complete or partial or significant resolution of tinnitus. So all of the 11 patients that I also, in this 8-year period that I sectioned the cochlear nerve, all reported that they had a significant improvement of the tinnitus. And that's unusual for all other causes of tinnitus. Okay, so these patients also, vestibular nerve section plus cochlear and simultaneous Baha. Again, all patients are consistent Baha users because it crosses the sound to the good ear. So it's a very nice treatment for single-sided deafness. Now you've made this patient completely single-sided deaf, but they get benefit from the Baha, and all with complete or significant resolution of tinnitus. Okay, so let's go on to the next section. Let's see. Okay, that's the end of that. So do we have any questions about this before I go on to the next topics? Питання? Okay. Dušan? Oh, there is something that I said I would mention, I have to remember. So why not just a labyrinthectomy? Well, I have 3 patients, one with small acoustic neuroma, one with previous labyrinthectomy, and one with some epidermoid, 3 patients that had labyrinthectomies and still had a connected vestibular nerve, even though there was no hearing in the ear, that still had vestibular symptoms. It's very unusual situation, but in my 30 years of time, I've seen three cases that still had residual symptoms and improved after the nerve was sectioned. So it doesn't make sense, but it is explainable on one basis, that the nerve, even though it's connected to a non-functioning end organ, is still alive and is still giving some kind of a baseline input to the brainstem. And Dušan, we've seen patients, you have these patients, and that's another presentation. I think we presented this at one of our ENT meetings, that they had appropriate, 2 here in Serbia, they had appropriate unilateral vestibular loss yes. They had appropriate nystagmus of vestibular loss. You saw them immediately after sectioning their nerve that was connected to a labyrinth that already had a labyrinthectomy. So it's the closest thing we have to proof that the nerve, even if the nerve is still alive and it's connected to nothing working, it still can have some effect. So we actually documented this. So that's why I don't do only labyrinthectomy. Yes?
Just to translate.
Yes, please explain it, because it's very unusual.
Znači, u dugogodišnjoj praksi imaju 3 pacijenta kod kojih, iako je uređena labyrinthektomija, znači kompletna destruktivna hirurgija uva, pacijenti su i dalje imali tegoba sve dok nije presekao vestibularni živac. Što sada malo čini situaciju čudnom i teže objašnjivom, ali to je ono što smo pričali da iako organ koji je nervisan ne radi, sam taj živac koji je nerviše, znači vestibularni radi. Da kažem, to je ona neka možda i osnovna aktivnost njegova o kojoj smo pričali, aktivnost na nivou vestibularnih jedara, koje se ipak po presecenju živca gubi. A neki vid objašnjenja ovih par pacijenata, čak eto i nekih zajedničkih koji smo imali, koji, znači gospođa iz Niša, jedna koja je bila sa intrakohlarnim šlanomom, jedna nova ređi oblik šlanoma, gde je znači skroz razorio kohlarnu unutrašnju. Znači, ona preoperativno nije imala uvo. A postoperativno je dobila kontralezioni nistagmus.
And for sure on her surgery, the schwannoma had eaten away and destroyed the end organs. There was nothing. It dilated it, so there was nerve coming to no residual ampulla. It was gone. And still had. And the other one had a labyrinthectomy for previous, it had a cholesteatoma and an acoustic neuroma, and the cholesteatoma had invaded the labyrinth, and the previous surgeon did a labyrinthectomy, and he also had.
Znači, još jedan pacijent koji je imao već uređenu labyrinthektomiju u kombinaciji operacije srednjeg uva i vestibularnog šlanoma, kasnije po presecanju živca razvio nistagmus ka zdravom kontraleziju.
Yeah. So for me, to add the vestibular nerve section once the labyrinthectomy is done is a very small amount. It just adds a little additional risk of CSF, but it's very easily controlled, and it pretty much guarantees 100% disconnection. All right? So it's worth it. For me, it's worth it. Right. Because I've seen that. That's why. So I'm going to talk a little bit, not too long. I want to go over some facial nerve surgery. And then we'll go to acoustic neuroma. We have, how long do we have? It's like 10 to 5?
As much as you like.
Okay. Good. Okay, so we don't have a limit, which is nice. So facial nerve surgery is a very large part also of neurotologic surgery. Okay, I know we're speaking mostly about vestibular surgery, but there's a whole area of facial nerve science as well. And it also is crossing over to neurology, so I think it will be very interesting for all of us. This is Polish. See? Twarzowego is facial in Polish. So, I recently gave this lecture in Poland, so that's why I have it. So, let me see previous. Let's go back to, yeah. So, the main causes of facial nerve paralysis are either infection, which we believe that Bell's palsy is a viral infection, or tumors. Guza is tumors in Polish. Or trauma, or iatrogenic injury. I mean, this is the main causes of facial nerve paralysis. The overwhelming majority, most, najviše broj je infekcija virus. Okay? Now, let's talk a little bit about Bell's palsy because it's neurology. So, in the United States, about 12 years ago, the Academy of Otolaryngology in the United States made some determination about the indication for facial nerve decompression in Bell's palsy. And the conclusion that was reached by the Academy was that vertical or in the mastoid is completely not indicated because there's no benefit. And that's not the site of lesion. The lesion is in the internal auditory canal at the labyrinthine segment. Then they concluded that steroids early is a major treatment advantage, so steroids should be given. Now it's interesting because there still really hasn't been done a randomized, double-blind control trial. Because imagine you're going to go to the clinic and the doctor is going to tell you, we give you steroids usually for this, but if you'd like, we can enter you into a trial where you'll either get steroids or no steroids. What would you say as a patient? You say, well, what would you usually give me? You say, well, we give you steroids. I say, so you're telling me you're going to give me a 50% chance of not getting any treatment? I said, yeah, that's what we're telling you. So we can know whether or not the treatment really works. What would you say if you're a patient? You say, forget it, give me the steroids. How bad are the steroids? I said, not so bad. Okay, so that's why it's never been done. We even tried to do such a trial for post-operative facial nerve paralyses after acoustic neuroma temporary, and of course we couldn't get anybody to do it because they all wanted the steroids. So we really still don't have the highest level of evidence about steroids even. As far as antivirals, there were good large trials done in the United States at least 15, 20 years ago that showed that antivirals don't make a difference. So in the US, we don't give antivirals for Bell's palsy. But we have to consider Bell's palsy different from known herpes zoster oticus or a patient that clearly has recurrent herpes simplex infections. And there are differences. So those patients, of course, will be treated with antivirals. So if you have Ramsay-Hunt syndrome, absolutely antivirals are indicated. If you have repetitive documented herpes class viral levels from the blood, yes, they should be treated with steroids. But routine Bell's palsy, we don't give it anymore in the US. It's not wrong, but it's just not done anymore for the US. There is another group of patients that I also give steroids. If a patient had any kind of operation around the head and neck area, even dental operation, or something in the face, there are reported about 1 out of 1,000 people. I've had it myself for one of every kind of operation that I do. I've had at least 1 or 2 patients that have a delayed facial nerve paralysis. Even for simple tympanoplasty, without any exposure of facial nerve. Stapedectomy, had cochlear implant 2, with perfect facial nerve, no injury to facial nerve, 10 days or a week later, develop a facial palsy. And this is well documented, and it was studied that after even acoustic neuroma, you can have 10 days later facial paralysis. Now this cannot be from trauma from the surgery, because if you injure a nerve from an operation, you're going to expect to see loss of function within 24 hours. But this happens a week later. And in these patients, there have been studies that measured the herpes class viruses in the spinal fluid, because these patients, we have access to the spinal fluid. And they showed high levels of herpes class viruses. So these patients, it is indicated to give them steroids. Anyone that has a post-operative delayed facial palsy also gets steroids and antiviral therapy. But there's a rare, but it's often enough. If I have 1,000 here, 1,000 there of each kind of operation, I can think of maybe 10 of patients that have this. 2 implants, 2 stapes, 1 tympanoplasty, they're going to have it. It's going to happen to everyone. Now, what about surgical decompression? Well, in the 80s, Ugo Fisch in Zurich, and then in the 90s, also 80s, late 80s, University of Iowa did a study very good studies that showed that you have to measure the percentage of degeneration on the facial nerve by doing electrical stimulation with a bipolar electrode, surface electrode, and measure the amplitude of the reaction of a surface electrodes, right, stickers, at the nasolabial fold. And you have to compare the normal side to the paralyzed side, and the patient should have a complete paralysis documented by needle EMG showing no activity at all. So if there's any activity from needle EMG test, no decompression. So it has to be complete. And it should be 90% degeneration or more. So even if there's no movement, if you can still stimulate the nerve and get activity, then those patients are going to recover to normal. So you don't need to do any decompression. But if you test them, and this is the graph of how severely degenerated it would be after a certain number of days. So we go up 1 week, 2 weeks, and 21 days. If the patient still has, let's say, 40% at 14 days, you just repeat it in another few days to see that it doesn't completely drop. But if it drops below this red level, and many of us, like myself, also use 85. I'm not going to say he's 85, he's going to be okay, because the numbers that you get when you do this test, they're only small numbers. It's like 1.0 amplitude as opposed to 0.2. So they're actually small scale. So if it goes down to 0.2, I'm going to say that's pretty bad, especially if it's early. And these patients benefit significantly from surgical decompression. Now, this is a very small group of people, and you have to find them within the first, ideally, 2 weeks. So only in my center in the United States, where I was chair of neuroscience, and I had colleagues who were neurologists, who were neurosurgeon, who were ENT, and we were all in the same department. Only there did we do 2 a year of decompression of the facial nerve, because almost all other centers, they first go to emergency room, and then they give them some steroids, and they give them follow-up appointment with neurologist, and that may be in 1 month, and you never find them in time to do the surgery. So if the system is set up to find the patients, then it's very reasonable. But in the United States, again, they made a statement that though we agree that there is benefit to doing this operation, there are so few centers that are set up to do it properly and so few surgeons that are trained to do it that we cannot say that it is recommended, because then you would have more than 95% of the United States population claiming that they didn't get the proper treatment, right? Because the treatment is really not available. But I do it when it comes up. And now, I'm traveling from different countries, so rarely, it doesn't come up. But it's the same operation as for a small acoustic neuroma, okay? So it is indicated. And you can see, what do you see? This is from the top down, the middle cranial fossa. This is the superior semicircular canal. This is the geniculate ganglion. And this is a little tiny area where the labyrinthine facial nerve comes out of the internal canal. And this is about 0.5 millimeter in diameter. And this has to be decompressed with the bone taken off of it. And it can only really be done by someone who does a lot of acoustic neuroma surgery. Okay? Now, let's talk about facial nerve trauma, because this is probably a next common cause. This patient has a transected facial nerve. This is a transverse fracture of the temporal bone on the left side, okay? Right through the left side, completely deaf, vertigo, right through the center of the facial nerve. You can see clinically he has no movement, and this is about 24 hours after surgery, after the fall. So there's no question that this patient has a transected facial nerve with the fracture line going directly through. So what do? I'll show you what we do here. Is in this situation, because he doesn't have hearing, I can also go through the labyrinth. So I don't have to do any craniotomy, I don't have to lift the brain. He's already deaf, go completely through the labyrinth, and I'll move it up a little bit. First we tested him. Here is a surface E-NOGS. We call it electroneuronegraphy. This is the amplitude of the waveform, and we take the current that gives him the maximal amplitude, and then we use 110% just to make sure that we get enough current in, and we see that he has completely no response. So this is indicative of a totally severed facial nerve. If it was partial, we would still get a response, and we would do nothing. We would let him, because in a trauma, you don't have a time limit. You know, if he gets no recovery, you can always go back in up to a year and a half later and graft the nerve. It's completely okay to do it delayed. So this is important because, you know, we don't have to forget about the patient. Even if they didn't get anything done immediately, it can always be done later, okay? And here, the nerve, I'm opening this up. This is the internal canal, like I showed you before. This is the labyrinthine nerve, and this is the sectioning right through the center of the nerve. So what I did with him, and what I would do with anyone with a transverse fracture, I would separate it. It's very swollen, and here are the two ends. Clean them up, and then move this nerve back by taking the bone all around the internal auditory canal, and move the nerve back so I can nicely make a single anastomosis and just put a few sutures. I'll show you that here. It's clean, and now I'll put a stitch. This is all spinal fluid because he has a fracture through the inner ear. And I'll put a stitch right through, and you only need to do like 2, 3 maximum. You just so that the nerve is actually touching the end, because it'll regenerate right across. You don't have to be so specific, just to get the outside of the nerve to touch, the ends to touch and not to move, okay? This was actually done about 20 years ago in Poland, so you can see this is a PAL video system, standard definition. And this was the only nylon suture smaller than a 5-0 in the whole hospital. They found it in the urology department for suturing ureters. So we had 1 suture to work with for the whole thing. And we just put about 3 sutures. And just to show you what he looks like. So here he is. Remember, it's this side. He has good tone. He doesn't have controlled movement, but he's able to close his eye. He's able to speak. And basically, he's telling us, yeah, for everyday life, I feel pretty normal. See? He's like, I'm okay. So this is what we expect with just suturing the nerve together. And this is what you would expect if there's a nerve that's cut from operation in the ear. If you can get the 2 ends together, then they will end up like this. It's hard to put a number to this, you know, using a grading system. It's not really relevant. It's what is this grade? This is grade 3 because he closes his eye, but it's all one mass movement. So it's synkinesis, grade 5, close eye, grade 3. You can't really use these grading systems for this. So this is acceptable for this outcome. Young, healthy person, it's acceptable. Now, facial nerve tumors. This is a young girl, and she had a very long tumor going from her parotid gland all the way up to her middle cranial fossa. And I put a single suture in the internal auditory canal, and I ran a graft from the sural nerve to the parotid. And I'll show you other examples of this too. I have some with video also. And she has relatively good smile, a little bit of a weakness, some mass movement, and good eye closure. So because she's so young, she was 14 years old, she had a relatively good outcome from just a long graft in between. Now, there are better ways to do it now. This I did about 20 years ago. This girl also is about 20 years ago. She had an extremely large acoustic neuroma. I was supposed to arrive in the hospital in Poland on the following week. So I was about 7 days away from doing this surgery. And my colleagues called me that they just took her in emergently through the emergency room because of starting to lose consciousness. So she had about 6-centimeter tumor, and she's 18 years old, and she started to lose consciousness. So they put a drain in her ventricle to relieve the pressure, and she woke up, And they asked me, what should we do? I said, well, you can't really wait a week, and she was in and out. It wasn't perfect, this drain. I said, okay. It was the first time they were ever going to do an acoustic neuroma with my help. I had worked with them in the temporal bone laboratory only. So I said, listen guys, I showed you how to do at least 4 times in cadaver. Just do the best you can and forget about the facial nerve. She's gonna die. We can always repair something for her facial nerve. So they did exactly that. They took the whole tumor out, completely cut the facial nerve on purpose, and did a very fast operation. If you cut the facial nerve at the beginning of acoustic neuroma operation, it's actually very easy. You don't have to identify anything. They go around and they saved her life. And they took whole tumor out, a giant tumor. And I'll show you then what I did when I arrived. She was only about 3-4 days after surgery. She had a complete paralysis. There's what we call Bell's phenomenon. When they close the eye turns up and it covers the eye. She has no Bell's phenomenon because it's too early. She's only 3 days, whatever. So she has no Bell's phenomenon and complete paralysis. And what I did is, because she just had a surgery, I stayed out of the surgical field and I did a hypoglossal to facial anastomosis. So here's the hypoglossal nerve here. Here's the hypoglossal nerve over the carotid artery and the digastric muscle, just underneath the digastric muscle. And I put a sural nerve from her leg. We cut halfway into the hypoglossal nerve, not to completely eliminate hypoglossal function, and then sewed it to the end of the facial nerve. And I'll show you in the next video how she looks. So remember, she has function on this side. Unfortunately, they didn't have at that time any gold weight or anything like that, so they put a Teflon spring into the lid and it eroded through the eyelid and scratched her cornea, and she has corneal opacification. So that it's very important that the eye, even if there's nothing can be done right away, with a patient with a complete paralysis should have the eye, you can just suture the eyelid closed at about 1/3 of the way so they can still see through the eye, but they've got it almost completely closed. And that'll protect the eye until something definitively can be done. But that wasn't an option. Well, it was an option, but they had this spring, and I said, okay, guys, go ahead and put it in, and it had a complication. But here she is. You're going to see this is a patient only facial hypoglossal. Of course, the fact that she's young helps, because the younger the patient, the better they regenerate. So remember, it's on her left side, and you watch, she has good rest symmetry. When she speaks, of course, that side doesn't move so much when she speaks. You'll see her speak a little bit, but when she swallows or thinks about moving, you see, that when she speaks, the mouth comes over this way a little bit, but she has good appearance. She doesn't have this paralysis anymore, and this is completely acceptable cosmetic and functional appearance with one operation. See, so she'll show you, she'll swallow. See, she's able to swallow and move her face. But with the hypoglossal nerve, they have to think about swallowing or moving the tongue in order to get the face to move. And that's because the 12th nerve is relatively far away from the 7th nerve in the central nervous system. So they still have a little bit of thinking to do to get it to move, all right? And now we have better options than this. So here she is. So there's another operation that back in 2010, myself and one of my partners in Chicago came up with a minimally invasive technique for reanimating the facial nerve, and I'll show you that. But first, I'll show you the operation that it's based upon. So the operation that it's based upon is, this is a patient that had a recurrent carcinoma, and this was his 3rd operation. So I took his temporal bone and his whole parotid out with the facial nerve. He only had a piece of the marginal mandibular nerve left. So I put a graft from inside his middle ear to that. Okay, so he has that. So you'll see the earlier films, you won't see much of it active, but then the later films, it'll actually contribute a little bit to his movement. But what we did is, it's called orthodromic, meaning in the direction of the muscle, temporalis tendon transfer. So the idea is to take the temporalis muscle, and it requires an incision up here in the scalp, because him, it's not a problem. He already had a big incision there from parotid surgery, and suturing it to the mouth. Okay, so we transfer it from the coronoid process of the mandible to the mouth. Here's the zygomatic arch. We just cut the zygomatic arch out, and here's the muscle, and just pull the muscle through, and tendon, and use either some fascia lata or some artificial materials like allograft dermis, which is not necessary, but it works very nicely. It doesn't require another incision, but it's expensive. So I'll show you what he looks like. Let me put the volume up. I think I can actually, yeah, if we can hear. So here he is after this operation, a few months. Now, if you can understand Chicago English, he said, everybody keeps telling me that they can't even tell. Now, you notice, what's interesting is that he actually moves and looks better in many ways than the ones who actually have nerve grafts. And the reason is, this operation is only giving movement to this part of the face, while the nerve grafts, they get a lot of synkinetic reinnervation. So when they smile, the eye closes also. So they can't control the movement as well. So today, and I'll show you examples, I use multiple techniques to reanimate the face so that the patient can separate out these movements. Even if they put a nerve graft, I'll also do this. And I'll also put a gold weight. And I'll also do something to the brow so that they have many different parts of the central nervous system controlling it, and they can learn to do that. Look at this. Here he is. I'm going to show this one. He gets a cell phone call, and he gets annoyed. So unlike the lady that has the hypoglossal facial, he's using his fifth nerve to move his face, and the fifth nerve is very close to the central nervous system, to the seventh nerve. So watch, he will spontaneously make a facial expression with his fifth nerve. So he's just gonna watch how he's gonna look annoyed when his phone rings. That's it. He made a face, you know? And that's a emotive facial response, which is really not possible with many of the other responses, even though it's not from the facial nerve, right? So there's a huge advantage to breaking up the reanimation. This is the paper that we put out in 2011. Here is the first patient we did. This was before and after. And so what we do now is I move. It's the same operation, except it doesn't involve making an incision here. And instead of taking the temporalis tendon off of the coronoid process, I just cut the coronoid process off, because you don't need the coronoid process of the mandible. It's a completely extra piece. If you're already removing the muscle that goes there, you don't need the process. So we just cut it off, and by cutting it off, we can suture to it. I don't do this with an endoscope, but I used an endoscope just to show it so that you can see what's going on. A lot of this is done by feel, just with a finger to feel it. So here's the coronoid process. When she's moving her mandible, this is the temporalis tendon, and this is the coronoid. So I just put a saw, here is a reciprocating saw, and cut off the process. All right, I won't show the cutting it off because it sprays blood everywhere. Oh, sorry, I went back up here. So here is, once we cut it off, you'll see then we have it completely free in the hand. So here's the process. Now I suture the fascia lata tendons to this piece of tendon and bone, and you can get a very strong, secure suture to this tendon and bone. You just put this permanent sutures above the bone, okay? And I'll show you what these patients look like. I'm going to move, see, and then I pull it through, I sew it to the corner of the mouth. I also run a piece through the lip to stabilize. Remember when you saw this girl, the one that had the acoustic drum, when she speaks, the mouth is going across, right? Because the normal side is pulling the mouth like this. Well, I put a piece of tendon to hold the lip in the center, so when the other side is speaking, it's not pulling across, okay? So that's what that does. And let's go now to a little further and show her, and I'll show another patient. This is a patient with both operations. He had a nerve graft, like the girl, the very young girl, and this operation. So first I did, here he is before any surgery. He has incomplete eye closure. He has a facial nerve tumor. He has incomplete eye closure. And when they have incomplete eye closure is the time you should intervene and do a surgery and take out the facial nerve. Because when you do that, here I did it through a middle cranial fossa, and I'll skip through the film right now just because I've shown enough. Here he is immediately after that surgery. He has now a complete facial nerve paralysis, all right? So what we'll do, I take him back to the operating room about 2-3 weeks later. You know, I don't want to mix an operation that's right near the mouth with an operation in the brain because we do expose the mouth at the time of surgery. Fortunately, it's not a big risk of infection because the mouth heals very nicely. The facial area has so much blood supply that even though we have our hand and fingers in the mouth while we're doing this operation, I've only had one patient get an infection of about like 50 of these, and she was a young girl about 6 years old, and she had a dental abscess. So that was the source of her infection, actually. So it's important to check these patients. Also, a gold weight, here he is, and watch, here he is a year after surgery. So watch. So he closes the eye nicely from the gold weight. So he's able to move it. Some better, so it's a little weaker here, but watch this. So now watch this. Here he is 8 years later. Over time, it actually improves because the nerve graft that I put in now is fully functioning, and he's learned to coordinate things different. The gold weight is actually extruding, so this needs to be revised. I made this film like the week before I left the United States, so I sent him to an ophthalmologist. They just have to pull it up and put a stitch in. But watch how nicely he's able to move, and he can whistle because the nerve graft is working.
Go ahead and smile.
See, he has more strength from the nerve graft now also.
Your lips like a fish mouth. Good.
And more strength here as well.
And you can whistle.
So he can even whistle. Let me go forward a little bit, and I want to show you a couple of patients done here in Serbia. This patient, so here he was, this patient came from Texas, he's Serbian, and here he is immediately after, about a month after the facial reanimation. The month earlier, I had taken out the tumor and put a graft. So I put a graft going from his brainstem to his parotid, right? So he had a pretty good-sized facial nerve tumor. And here he is after that surgery, and here he is after the first stage. He's all swollen, you know, it doesn't look so great. But let's go now. Here he is 1 year after operation. He went to visit Montenegro, and he sent me this film.
This is it.
So remember, this side,
Starting to move.
so he has nice control over it.
They all healed up here.
I did a brow lift also, because his brow was starting to droop down.
My eye is still
So,
gets dry. I mean, it's humid. It feels wet. It feels good.
here's another lady. I just did her a couple of weeks ago. Here she's about a month or so, 3 months after. She also had a graft put in, but it's only 3 months, so the graft doesn't work yet. But in a year, the graft will work, all right? Because of cost, we had to do the eye as a separate operation, right? So we could do first the tumor, then this operation, then the eye. So she had 3 surgeries, but look how she looks. Here she is with just this at 3 months, just that temporalis at 3 months.
Okay. So, can you go ahead and close your eye?
So she doesn't have to wait yet. I'll fix that.
Okay, open your eye. Good. Can you smile?
Now watch how much control she has. Look, watch. She,
Yeah, good.
see, she has
Looks great.
complete independent control of that.
Tell us quickly what you had done so far.
And in a year's time, this will get the nerve graft, and this will be a lot better. Okay? So I think that's it. I have a couple more people, but we'll move forward now. Oh, here, let me show you him. Here he is 2 years later. He's even better now. Watch.
And here is the
See, he has more movement of the lower lip.
most recent one.
And he showed me something which gave me an idea. A mini facelift. So I do that also now. I add in older patients or a man with, big, I do a little mini facelift also. Or there's also threads I'm thinking about trying also, these threads to put in, because he has a little bit of drooping there. But you see, so compare this to what some of the earlier patients were with just a nerve graft. They look a lot better by using many methods, okay? And good. So any questions? Okay. Now, what time is it? So what should we do? I have a little bit about acoustic neuroma. Should we do, or it's up to you? Okay, I'll try to keep it to the minimum because I'm going to skip through most of the surgery videos, but I want to show you some very interesting things about the management of acoustic neuroma, okay? Because this is something that is getting a little bit lost in the literature. And this was I presented this a few times in Serbia. It was published in the Serbian Archives of Medicine as a monograph, so you can find it in Serbian. And Natalia is a co-author on it also. She helped us put together the manuscript. And it should be coming out. It's under review. It was accepted by one reviewer and the second in an English language journal. So it should also come out as a formal paper in an English language journal soon. But when it does, it'll be on my website. So again, I told you about this. So let's look at just quickly about how many people in the Balkans do we think have an acoustic neuroma? How common really is it? Well, autopsy studies, which was the first group of studies going back for many decades, estimated that 1 in 100,000 have an acoustic neuroma. This is probably very low because recently there have been MRI studies, all right, that look at, and one was done in California, these are in English language literature, another one, this is in San Diego, show that it may even be as high as 20 from 100,000, which in the Balkans, if we look at the whole Balkan Peninsula, including parts of Turkey, we may be up to 11,000, which is a lot. If we actually just look at MRIs done for asymmetrical sensory neural hearing loss, we can get 2,000 to 8,000 per 100. So asymmetrical sensory neural hearing loss MRIs can be 35 to 50% depending on the study. This is probably too high to say that there's more than 2 million in the Balkans, right? But it's probably closer to this number. And this was random acoustic neuromas looked at on MRIs done for all reasons, not for the ear, just incidentally located. So it's probably 20 times higher than what has been commonly thought. And it shows, we see a lot more, we see many acoustic neuromas, and it's considered to be the most common intracranial tumor. So it is a very, very high incidence of acoustic neuroma. Now, I'm going to go through a little bit of this, and I want to talk specifically about how to make a decision about what to do for them. Because today, if we go and we look at what are the main options, right? the simplified version is to say we either operate on them, or we continue to observe them, or we give them radiation therapy, right? And those are the three main options. But I'm just going to start off by saying that way too many people right now are getting radiation therapy. And there's a reason for it, is that, when I trained in my original training, we did at least 50 to 100 a year in our one center. And I was there for 8 years plus the years of residency, another 6 years. So this is a lot of acoustic neuromas that we operated on. Well, today, there's nowhere that it's doing that kind of number of acoustic neuromas. It's becoming more of a rare thing. So if we add to that in another 10 years of experience, there are going to be very, very few people left. And in many countries, there are very, very few people who are comfortable and confidently skilled to do this operation. If they do the operation, they do partial removal, right? And there was even a period of time in the United States about 10 years ago where this was being advocated. Just do partial removal and give the rest radiation. So they're saying this is the safest way. Well, that's also the most expensive way. And I want to show you some studies that talk about the risk of those methods and what the expected outcome is going to be. So there's some very important information. Now, when I look at a patient, I don't look and say, okay, your tumor is 2 centimeters, and because it's 2 centimeters, you should get this. And a lot of papers and a lot of centers do use that method. They just look at an MRI, they look at a number, and they say, that's what you need. Okay? Well, that's not really taking care of a patient. And every time I give this lecture, there's usually other lectures by neurosurgery departments, radiation departments. And recently in Poland, we had a whole seminar on acoustic neuromas, and I was the third speaker, one neurosurgeon, one radiation doctor. And then I was the third, and the first thing I said is, okay, did anybody hear the word vertigo mentioned at all in the last 2 lectures? And the answer was no. So you can find many studies about recommendations for acoustic neuroma, and they won't even mention vertigo. And what is acoustic neuroma? It's a vestibular schwannoma. 99% are from the vestibular nerve. It's a vestibular disease, and the patients have vestibular complaints. So in most of the neurosurgical centers, not only is hearing also not really considered an entity, but vestibular complaints are not even looked at, not even thought about. And in gamma knife centers, they're not looked at either. Because if the patient has vertigo afterwards, what do? They send them to a neurotologist and say, okay, you're dizzy. Yeah, you have an acoustic neuroma. Bye. Go see somebody about that. And this is extremely common. And I want to show you, what I do is every patient, I'm going to go through a little of this because this is very long, but I just want to show you the main things. Every patient has to be looked at in terms of all of their symptoms, specifically vestibular symptoms. And I want to just go forward. Let me go forward to some things that are very important to keep in mind. Now, let's think about hearing preservation for a moment, all right? And a lot of the argument about using gamma knife is to preserve hearing, right? Now, when neurosurgeons do hearing preservation surgery, they use a craniotomy, and they don't go through the labyrinth in order to save the hearing. Well, what's the real percentage of success of that? And this was looked at carefully decades ago in the US. So we can kind of forget about this right now because this was a little outlier in smaller numbers. So look here. We have relatively low success rates in tumors that are over a certain size. So if we look here, if we have a tumor that's smaller than 1.5, yes, we have a good chance of saving the hearing. 1.5 centimeters. For me, 1.5 to 2 centimeters, that's the maximum I'll even think about trying to save the hearing. because anything bigger than that, it's almost impossible. See, look here, 3%, 5%, 2%. Okay, Sami in Hanover says 25%, but he uses a completely different system of determining whether it's extracranial or intracannulicular. So we really can't look at that. Here, and if we look at 1.5 to 2, it's about 20%. So 80% you won't be successful when you get over 1.5. If it's bigger than 2 centimeters, you're at single-digit percent. So there are many patients that will be offered by myself, by many trained neurotologists, translabyrinthine, safest way, no manipulating the brain, go in, but we're going to sacrifice the hearing at the beginning. And they may be told commonly by a neurosurgeon, don't let those crazy guys operate on you. We're going to do everything to possibly try and save your hearing, even if it's a small chance. Well, what's the real chance? The real chance is less than 5%. So in my opinion and of my colleagues, you have 95 to 98% of failing to save the hearing, and you're being subjected to a riskier procedure, which actually has twice the level of spinal fluid leak rate. And that there's another data we did, many hundreds of patients we looked at, and it was impossible to get better than double the spinal fluid leak rate using a retrosigmoid or craniotomy approach than it was using a translab. Because going right through the inner ear, you're able to completely block the eustachian tube. So we have half the complication rate. And when they do a craniotomy, many of the patients stay intubated for a number of days. There's compression on the cerebellum. They wake up slower, and they have delayed recovery of vestibular symptoms because in order to try and save the hearing nerve, you have to leave as many of the nerves as possible. So you don't cut all the nerves. In translab, when you know you're going to go through everything, you cut all the vestibular nerves. So you give them a complete vestibular lesion, and those patients recover from their vestibular symptoms much faster. All right? Now, let's now look a little bit about radiation. This is spinal fluid leak data. I spoke about this, but I'm going to show you about radiation. So I also do radiation. I was certified in the United States to do radiation. So there aren't too many neurotologists that are trained and certified in craniotomy, transtemporal, translab, middle fossa, and radiation. Okay, there are only a few people in the world that are actually using all possible ways of treating. So my opinion is based on having done all the things, not just trying to give some propaganda to take the patient and say, those guys do this, those guys do that. I actually do all of these things. So let's look for a second. If you give radiation to a tumor, this number, 4 gray, 12 gray is a radiation dose. Radiation is measured in gray today. It used to be called rads. They divided by 100 and gave it a name gray that sounds better than rads, okay? So to make it more friendly. That's clearly the reason. This is 1,200 rads, okay, but 12 gray. The cochlea, here's the cochlea, is sensitive at around 4 gray. Higher than 4 gray, you're going to induce hearing loss of pretty significant probability. Well, look, this is a treatment plan, an actual treatment plan. This is a tumor that's about 1 centimeter, and it's away from the cochlea. Here's the internal canal. This is not a common picture. You usually see the tumor located here. So if this is 12 gray, and it's this far out to get to 5 gray and then 4 gray, this is about the optimal situation, and this was a 75-year-old patient without any vestibular problems. This is a reasonable patient to treat with gamma knife, and this was my patient, and I treated him with a gamma knife, okay? Because I can get a safe dose to the cochlea, and he's elderly, and I only need it to work for a certain period of time, and even giving, and this is a very low dose, and that's okay in this situation. But the typical acoustic neuroma, it does not look like this. The ones that are being radiated all over the world today look like this, even very big ones, even up to 3 centimeters, sometimes bigger. They're being given radiation. Well, when you're doing that, you can almost certainly, and the statistic is actually about 75 or more of all sizes will lose their hearing by 10 years. So the preservation of hearing with Gamma knife is actually not so good, okay, over a long period of time. But you see from this that you have to have almost an ideal situation to not give a toxic dose to the cochlea. Now, when you give this kind of radiation, right, 12 gray, at the outer edge, you have a peak. It's called the 50% dose line. And the dose looks like this bell curve. And that 50% dose line goes out here. And the center is getting, if we want to figure out what's getting 20 gray, and I'll tell you why in a second, why 20 gray is important. The volume of the sphere, because this is cubic, it's geometry, this is 21% of the total volume. So about 80% of the volume is getting less than 20 gray. Why is 20 gray significant? Because in a laboratory environment on human schwannoma cells, it takes 20 gray to kill them. So anything less than 20 gray is a non-lethal dose. It's inducing some kind of fibrous reaction, but the cells are still alive. So you're giving 80% of the tumor a dose that still stays alive. Now, it works because it's causing some vasculitis, some scarring, so it has an effect, but you're not killing the tumor. So the idea of it being radiosurgery, where it sounds like you're taking the tumor out with the radiation, you're not killing the tumor, you're just scarring it. And if you have more than one single sphere, that's a theoretical single sphere. If you add more, and you usually have anywhere from 5, 6, sometimes 12, sometimes very complicated, the actual high point of the dose goes smaller and smaller and smaller. So in a multiple, you end up with a tiny percent of the actual tumor getting a lethal dose. So you're giving just a few percent a dose that kills the tumor. Now, starting in the 90s, around the mid-90s, is when we had the beginning of a large number of patients getting Gamma knife. Of course, Gamma knife was invented like in the 60s, and it was used for different things, but in small numbers. But around the 90s, this is when at NYU, New York University, our hospital got one of the first Gamma knives, one of the early Gamma knives in the country, and that's when we started doing large numbers. And that was pretty much the story all over Western countries, you know, Germany, Switzerland. They started doing it in the 90s. The dose that was given was a very common dose in this period to give 18. The beginning 20, 18. Then there were a lot of people who got 16. I remember dosing people at 16 gray. Now, they figured out a number of years later that 13 is kind of the toxicity limit. And what is toxicity? It means facial spasm, deafness, you know, all of these other problems, trigeminal neuralgia, vertigo, all of these problems. So in the last decade or so, the dose has been pushed down below 13. And when I left the United States, you see 12 gray, and now it's pretty much stayed that way this last decade. Before that, it was about 12.5 was considered the dose, you know. So most of the patients that we treated the decade before were 12.5, below 13. Now they're going down to 12. Well, what does that mean? That means that all of these patients who are being looked at in larger studies for having tumor control had much higher doses than the patients that we're treating today. So a lot of the data that you'll hear presented has control rates, no growth rates of these doses, and complication rates of these doses. So it's too soon to say what 12 gray is going to actually do to patients. And there are some studies also in terms of hearing loss. So here's final hearing. This is from Pittsburgh. This was presented at the course for Gamma knife, for training. A neurosurgeon presented this. You could tell he was one on faculty that was maybe a little bit skeptical, because he showed us And you could tell by his tone, he said, look, we're publishing 97% retained measurable hearing in patients that had 10 years follow-up or more. But it's actually a very small percent that had actual usable hearing, right? So the overwhelming majority were losing their hearing, but still they get reported even if they had class 4 or class 5, just tiny little bit of hearing, they were still reported as hearing retained results. So when you hear Gamma knife proponents say more than 90% of the patients keep their hearing, they're talking about this, non-serviceable hearing. See, class 3, 4, or 5 in this Gardner-Robertson, which is poor, less than 50%, less than 50 dB. It's actually useless hearing. And in many cases, problematic hearing. You know, tinnitus, vertigo, a lot of problems. So now, I already mentioned this, and I want to go through, I want to show some also very interesting studies. And this article will have this literature review. Here's 112 patients, this is around 2019, New York, 32% new vestibular symptoms. Tumors 1.6 centimeters were more likely to receive referrals for vestibular rehab. Okay, smaller schwannomas were significantly associated with higher rates of symptoms. Why? Because the smaller the tumor, the less damaged the labyrinth is. And the radiation is damaging a healthy system that has strong capability. So the bigger the tumor is, a lot of death or loss of strength has already occurred, and the patient has compensated. So the small tumors are often said, oh, you know, don't have any surgery, this is little, we'll just give you a Gamma knife, forget about it, you know, you'll be fine. Well, they have about a third of them are going to get new vestibular symptoms. They're going to get radiation stuck to the facial nerve. And then we have to ask ourselves, what's going to happen to them? And I've had patients where I've done only vestibular nerve section after Gamma knife because it's not worth it to take the tumor off the facial nerve because it's really stuck to it and very high risk. And I have had patients where I've just done vestibular nerve sections to cure their vertigo symptoms because the Gamma knife doesn't do that, which the operations do. Now let's look, what is the long-term outcome also? Well, here, acute vestibular symptoms, 100 patients, 47%, nearly half with new dizziness. In otology, worse if they had previous dizziness, okay? So, like I said, dizziness is not often even considered. Look, malignant transformation. This malignant transformation is 25 per 100,000 over 20 years. 10 times in non-NF2 cases. So NF2 cases have 10 times the risk of malignant transformation. And I've had many patients that I've treated who had Gamma knife as children, who had NF2, and then they have malignant meningiomas surrounding the area of the Gamma knife. So it's still used as a first-line therapy in many pediatric neurosurgical centers because the surgery is not so familiar for them. It's best to do nothing than to give them radiation, all right? Now let's look here. We also have some, look, 20-year malignancy, 6% for a Gamma knife, for NF2 patients. Now look, facial spasm, hydrocephalus, 9.4% of trigeminal neuralgia. That's a big problem. I've had patients that had very, very severe trigeminal neuralgia after getting Gamma knife for relatively small tumors and became narcotic addicts from that. So it's not benign, you know, this is the point. Let me just show you one very interesting study that relatively understudied complaint, vestibular, focus on vertigo. You know, vertigo is an understudied complaint along with tinnitus and the significant impact on quality of life. It's just not looked at in radiation centers. They just don't think about it. And let's look now, there's one nice study that shows us, yeah, here it is. I think this is it. Look, this is interesting. This was done in San Diego, 2006, 111 patients underwent observation, and then they compared them with a literature review, did a meta-analysis, including only patients receiving 12 to 13 gray. So the below 13 gray or less. and the growth rate was considered to be the same. So that opens up the question is, how long or does gamma knife radiosurgery actually control the tumor when they're very low doses? And are we just seeing the natural history even though they've been radiated? And if we radiate patients who are 20 years old, 30 years old, what's going to be when they're 50 years old? You know, and what's going to happen when the tumor begins to grow again? And we do see it. It's usually around 11 years later when I see patients who I've operated on that have had gamma knife previously, things will be under control, and it may be 11 years, 12 years, something like this, and then they'll start to grow again. And that's not just temporary swelling after radiation, that's real growth. And that tumor is much more difficult to remove because the radiation has stuck the nerve to the tumor. So those patients will frequently have subtotal removal, and I have patients like this that I could take everything out except a piece stuck to the nerve, and this has been a little bit changed, and then it may continue to grow after that, and if it continues to grow significantly, and this I just have a few, but it's enough to know, you end up losing the facial nerve and doing facial reanimation. It's maybe not the worst thing in the world, but there are patients that are going to require that. And I'm just concerned that in another 10 years or 20 years, we may see a lot of patients like that, especially the ones who've been giving these 12 doses. So this is the most important thing I wanted to get across about the overuse of radiation in acoustic neurosurgery. If you send patients to many centers, even here in Serbia, they will be told to get radiation. Yeah, explain that, yeah.
Čini mi se da ste svi dobro razumeli engleski, ali ajde pošto se koja reči na srpskom. Znači, samo ću ponoviti ovo što je Andrew rekao. Znači, nažalost, radi se o tome što mi, lekari, doktori, neurohirurzi, neurolozi, otorinci, nismo baš familijarni sa ovim podacima koji su izneseni. Znači, ono što je do nas, jeste da mi dijagnostikujemo pacijenta da ima vestibularni švam. Kako izgleda dalje priča? Pacijent ide dalje, sljedeća stanica je neurohirurgija. Da li vi znate šta se dešava sa vašim pacijentom koji ima vestibularni švam i dođe do neurohirurgije? Znači, bukvalno, izvolite, uđite, sede 3 doktora, potpišu, dame nož, a i u zgradu preko puta, on preko puta, do te mere da sam ja imao par pacijenata koje sam viđao posle zračenja koji su rekli da nisu bili ni obavešteni, ni informisani, ni znali da postoji kakav drugi vid lečenja. Na pacijentu je da izabere. Doktor mu predstavi, možete se operisati, rezultati takvi i takvi, šanse takve i takve, možete se zračiti. Ovde ne postoji mogućnost operacije. Ima više razloga. U Beogradu, koji je to neki centar za Srbiju, odnosno klinički centar Srbije, situacija je sledeća, aparat za zračenje, koji se eufemistički zove gamma nož, nabavljen je pre 10 godina, možda sad već i 11, tako nešto, ne znam tačno, prilike, sećam se po pacijentima, i poenta je što za ovih 10 godina se postupa upravo ovako. Svi pacijenti sa vestibularnim švanonom se zrače, sem kada dođe neki baš 4 cm, pritišće moždano stablo, ove ga operišu. Tako da trenutna situacija, upravo i ovo što je dr. Fishman rekao da se dešava i kod njih, što se dešava i u Americi, ali evo kod nas u Srbiji izuzetno, 10 godina unazad vi imate neurohirurgije na neurohirurgiji koji su možda operisali jedan švanom godišnje. Neka i 3-4. Koliko je on sada vešt da vas operiše i da izvadi švanom bez nekih komplikacija. Znači, čak i ako bi se sad odlučili, ok, doktore, ajde, ja hoću operaciju. Pa koliko si toga operisao? Koliko si uradio ti hirurgija? Prvo, nije tako baš česta patologija, opet ni videli ste, nije ni retka, ali o čemu se radi? Radi se o tome što su masovno ovih 10 godina, i nije se to se i dalje tako rešava, šalje na zračenje. I sad nisu to zli ljudi koji imaju zlu nameru, hoće da naude pacijentu ili da mu daju lošiju opciju lečenja, nego jednostavno uopšte nisu upoznati sa dosadašnjim rezultatima. Prvo, ono što pacijent očekuje, a i doktor što često misli, koji je poslao pacijenta na zračenje, da će time pacijent ostati bez tumora, da će to zračenje ubiti tumor i opravdati taj neki naziv gama noža. Međutim, tumor nije ubijen. Videli ste da u najboljem slučaju bude ubijeno 20% tumora, 20%, a 80% ostane živo, ali, da kažem, sad kreće poželjno izmenjeno i tako dalje. Pa onda ste videli da sad zbog komplikacija samog zračenja, trend od 90-ih i 2000-ih je smanjivanje doze, pa se došlo sada do doze od 12 koja je prilično nije toliko štetna, a se pokazalo da nije baš nešto ni korisna i sad se čeka neki dugoročni rezultat da se vidi da li uopšte ta doza išta i deluje u poređenju s onim da nismo ništa radili. A pak imamo podatke da je i tekako komplikacije su moguće počevši od, znači, neuralgije trigeminusa, problema sa facijalisom, a ono što je iz našeg domena sluha i ravnoteže, da pacijenti zračeni sa malim tumorom su imali daleko više vestibularnih tegoba posle zračenja nego pre. Što je dao objašnjenje u sledećem smislu. Kad je veliki tumor sporo je rastao i postepeno gasio funkciju te strane, druga strana preuzela funkciju. Tako da zračenje sad nema mnogo neke vestibularne. Mali tumor, još uvek je ta vestibularna strana, iako oštećena delimično, još uvek prilično funkcionalna. Tako da zračenje koje ste primenili je delovalo štetno i na sam lavirint, kao i na sam živac i može biti rezultat kasnije vestibularnih tegoba, koje se pokazalo da pacijenti često imaju nakon zračenja, a nisu imali pre. Glavno opravdanje i svrha cele priče je pričanje o sluhu, te da se sačuva sluh, te, da kažem, se pribegava zračenju, pa se onda pokazalo kako je kohla vrlo senzitivna na zračenje i kako neki dugoročni rezultat i nije baš tako dobar po principu očuvanja sluha. A onda se pokazalo da je bitan i hiruški pristup. Jedan hiruški pristup koji rade neurohiruzi je ovaj što se pokazuje ovde pozadnje, kraniotomija retrosigmoidni i pristupa se tome da se izvadi tumor, a da se sačuva facijalni živac i da se sačuva kohlearni živac, odnosno pacijentu se obećava da će se uraditi sve da se očuva sluh. Ali se ne kaže procenat. Da, ako je veći od 1,5 cm, da su šanse da se sačuva sluh nikako. Par posto. I onda, zapravo, pacijent se podvrgao jednoj prilično rizičnoj hiruškoj operaciji, otvara se glava, velike šanse postoperativnih komplikacija, curenje cerebrospinalnog fluida. Za razliku od toga da presečete. Ako su već šanse da se očuva sluh nikakve, bolje buši kroz uvo, neće sluha biti, ali će zato su minimalne šanse da bude postoperativnih komplikacija i isto tako su daleko velike šanse da se tumor ukloni u celini i da se sačuva facijalni živac. Tako da kompromis zavisi od lokalizacije tumora, veličine tumora, godine pacijenta i tako dalje, pa je da kažem na tu odluku, ali ono što je bitno i za vas kao lekare, pošto vi ćete viđati pacijente sa vestibularnim šnonom, da imate ove neke pouzdane parametre sa kojima baratate i u tom nekom smislu da i samom pacijentu predstavite kakve su mu šanse da se očuva ili ne očuva sluh i da bude upoznat i sa samim zračenjem i sa hirurgijom, pa nek on sam odluči šta bi od toga hteo. Kažem, naš državni sistem funkcioniše po principu, nema šanse da nađete nekog ko bi tumor od centimetar i po operisao, a svi će potpisati da se zrači, a kakav će ishod biti, pogotovo kod mlađih pacijenta, dugoročnih, posle 20-30 godina, evo čuli ste. Ali svakako, videli ste meni, da kažem, vrlo interesantno predavanje o rekonstrukciji facijalisa i, da kažem, ostale, da kažem, hiruške procedure iz ove neke naše head and neck surgery i cranial base surgery, sad koristimo ove engleske termine, znači hirurgije baze lobanje, hirurgije glave i vrata. Znači, videli ste kako stručnjaka imamo ovdje i, da kažem, mogu reći još jednom sad, nažalost, neiskorišćenog, ispada da mi ovdje u Srbiji nemamo pacijenata za ovog doktora. Eto, ako imate pitanja, bilo bi dobro da ostavite.
Add something else. Now, what we're beginning to do in my center in Poland is for medium tumor, a little too big to save the hearing, we're doing through labyrinthectomy, but we're also preserving cochlear nerve, which is easier to do by taking out the balance canals. You can see it, and putting in a cochlear implant. So now we're also doing hearing preservation, but through implant. Okay, this has to be done and paid for by government. Who will support this? Here, not yet. This wouldn't really be possible. We would have to pay from the pocket. But it's possible, you know, one would have to pay. But their government is actually paying for this also. And we're doing it by first putting electrode, a temporary electrode, and checking afterwards and seeing if there's electrical signal. So you can do a promontory stimulation with electricity to see if you can get some either patient hearing, clinical hearing, or some ABR. And also we're now developing all of this testing in the OR to try to check that it's worth to put this implant. But if we put a temporary implant, the electrode is okay. It's a small piece of silicone. It can stay. It doesn't have to be removed. So we feel it's reasonable to first make sure that the patient has some electrical stimulation. In many centers, they're just putting implant, which is an expensive test because some of these implants don't work. But we would like to make sure that they will work. So this is another, only for the last few years this is being done in US and in Europe. So there's better ways to give back the hearing. Also, this is one of my studies in center from New York, many patients, and for large tumors, we just looked at large tumors, and 90% had good facial nerve function after removal of large tumors. So, and you could see also that the results from facial nerve reconstruction is also very good. So, you know, if you have a big tumor, you're better off if you're a young patient with your tumor out of your body. You know, I'm seeing a woman right now that was given Gamma knife for more than 3 centimeter tumor and started to develop hydrocephalus. So now the discussion is getting her stable, clinically stable, to be able to take this tumor out safely. Whether or not facial nerve can be kept is a question because she had radiation and also some swelling of the brainstem. So this operation will be a lot more risky than if she just had operation at the beginning. But this is very common now. We see more of this because Gamma knife is thought to be simple, you know, treatment that doesn't have risk of surgery. Well, it has other risk. That's the point. It creates other problems. Okay.
Sava hospital. Sava Memorial Hospital.
Yes. Yeah, a few places. I'm working on a few places. There are a few, some patients I can do in the VMA, some places I can do in Avila Hospital, some in Sava, smaller. And then I'm also working now on arrangements for very high-risk patients, hoping to get the Serbian government to reimburse the payment in university in Lublin, Poland, for patients that I think need. We have their intraoperative CT scan. We have some technologies for navigation that we don't have here. So there are some operations that will really benefit from some of this high tech. And those patients, I would like to do them in the safest place. And I'm very close to having a Serbian government approve payment for out of the country. And in Poland, it's relatively inexpensive. Right now, Serbian government is paying for patients to get healthcare in Turkey. And this happens often. And Turkey is much more expensive. In Poland, they are only asking for the amount that the Polish government insurance would pay the hospital. So if you go to Turkey, it's maybe 5 times more expensive. It's like a big cost, and we are trying to keep it at a very affordable level. Okay, thank you very much. Thank you. Yes, yes.
We have a question.
Sure.
Yesterday, me and my colleagues, I'm Yulia, ear, nose, throat specialist, but I was studying in St. Petersburg.
Mm-hmm.
So my
decompression.
Yes. I'm doing this also.
Okay.
Yes.
Where are my colleagues, neurologists?
Yes. You can send them to me to see. I'm doing this also through very small craniotomy. I have a film if you want to see. You can see also, let me see, I can take it on, I have small film on this. It's on my website also, so.
Fishman, md.com.
We go here. And if we go specific clinical interest, and we do trigeminal neuralgia. So trigeminal neuralgia, microvascular decompression, is extremely effective if it's a classic presentation of trigeminal neuralgia. If it's atypical, it's less effective. But we say about 90% will get benefit for sure if it's all classic features. And so here I use a very small craniectomy positioned right behind the sigmoid sinus. Let's see. Let's let this, let's let it load a little bit. Will it go? So right behind the sigmoid sinus, it's about 2.5 centimeters. So I just remove a little bit of bone to be right, here's the sigmoid sinus, and to identify this location right behind it. And this is enough to do a microvascular decompression. And you don't have to repair this with anything because it's only about the size of a euro coin, right there. And I open this up, you can see the sigmoid sinus here, and look, here this is a US quarter. So the whole surgical defect is about the same as a quarter. And here is the bone over the sigmoid sinus. It's just cracked a little here because I lift this up. So we have a window. And by doing it like this, I don't have to push the brain very much at all. I just open here and release the spinal fluid. And we do put here, and this is the trigeminal nerve. You can see, and this is a vessel crossing. This is actually a very large vein. And you can see it on imaging. And I'll remind me, I have to tell you which imaging sequence you need to get. We have to separate the arachnoid and then put a tiny little piece of Teflon. This is a Teflon patch, the same that's used for cardiovascular surgery when they do attachments. They use this as a little bit of non-absorbable material. And just put it between here, and you can see, I can see directly, this is a retractor, but the retractor is not there to really hold the brain, it's there to rest the instruments, so I have better stability. So everything is it's a very atraumatic operation, and 90% success. And what was I going to tell you to remind me? Imaging, yes. Yes. I'm going to show you this. So the study that needs to be gotten is, let's see if I can find it here. I think I have it here somewhere. You need to get you need to get either Fiesta or CISS, and they're both high-resolution T2 images. Depending on the manufacturer, one is Siemens and one is GE, and I'll find it in the middle here. So here it is. So this is Flare or Fiesta, okay? And they're both sub-millimeter T2, and it's the same study that's used for looking at a small acoustic neuroma. You just need it through the skull base, and this is extremely high resolution. And you can see here is actually a very small acoustic neuroma. And on the other side, oh, I don't have it on here, but that's okay. Sorry, I have it on a different presentation, but this is the image that you need because just a few cuts higher is the trigeminal nerve. It's just a few images higher because the trigeminal nerve is just a little above here, and you need this thin T2 type image to be able to see the nerve. And if there's the nerve and there's a vessel pushing against it, and they have classic symptoms, they will do very well from surgery. And you know, you often see these patients that they have been treated with medications, and they're young and healthy, and they've been treated with medications for a long time. And I will operate on them even if they're controlled by the medications, but they don't like the side effects of the medications. And that's often the case. You may have a young, healthy person who's on medication, but they're very groggy, they're very sleepy, you know? Yeah.
Evo ovako kad gledate koliko je jednostavna ovo hiruška operacija, samo onaj dinarčić i mali otpor i samo gurneš ono i gotovo. Evo to je tako kad veliki stručnjak radi. Ja bih vas molio da jednim aplauzom pozdravimo profesora Fishmana.
Yeah, thank you. Thank you. Because they think, okay, they're controlled with medications, so why should we operate? But it's not reasonable. You should operate.